Hello. Hello. Uh, can you hear me? Hello. Can you hear me? This is check. Can you hear me? Hello. Hello. Yeah, can you hear me? Now it's okay? All right. All right. Okay. Okay. All right. So I'll repeat what I said. I don't know. Means the mic over here it was showing quite okay, but somehow it was not rerouting. So I just put it on another channel. So good. Now it's working. Okay. Great. 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 Perfect. So what I was telling. So welcome back. Right. So welcome back to our second session of this hip movers. I got just one or two mails regarding that when we'll be learning the nerve supply, when we'll be learning about some other aspects. The thing is, right now, deliberately, we are not touching the nerve supply. That is what we'll be learning in hip suppliers. Hip suppliers means we'll also be learning about the nerve supply to the hip joint and to all those muscles, right? So it will create a pattern. You'll understand that this is how the whole nerve supply really goes to that. Because now the voice should be fine. uh, Voice is not clear, Ankit, in that case, because it is, I think it is good to everyone, and there shouldn't be any problem now. Okay. So this is what we learned in our first session, right? That was the point where we left off. So this is like all those 1, 2, 3, 4, 5, 6 muscles, right? Piriformis gamellae superior, obturator internus, gamellae inferior, quadratus femoris. And underneath was the obturator externus. From this point onwards, now we are starting with the rest of the movements, right? Okay. So next, here comes the abductors. Oh, I'm sorry, adductors, right? First, let's take the adductors. Adductors are those which are getting the femur near, right? The femur near to the body, right? So over here, we'll be focusing on two surfaces. One, which is the exterior part, right? And that would be the ischium and the medial border, right? Medial border of femur. Obviously, it would be the medial border of femur, because when from the ischium the muscles will pull, so it will take this near to the center line. So that is what is called as the adductor. Now over here, see, there are only few muscles in this adductor. The name itself, that is so easy, right? So as we said, that entire adductor family, right? So this entire adductor family was like Magnus is like grandfather, right? Longus is like father, and that brevis is like son, right? So three generations of this adductor family. And then rest of the muscles, right? One would be the pectineus. This would be the shortest muscle. And graceful gracilis, right? So these are the five muscles which will be responsible for the adduction. Now let's start watching one by one. We start with the biggest muscle, right? Because what we are trying to do is we start with the base. And as we know that adductor magnus, that is at the base, right? So here is the giant adductor magnus. Now actually it is a magnificent muscle, huge, big one. If you really see, all the way it is getting connected, right? See, from here, this is from the ischiopubic ramus, right, the outer border, right. If you see, this is how it is getting connected, and all the way it is coming down, and then it has got two attachments, like one which is all the way onto this femur, and then there is one over here, the thing what is called as the adductor tubercle. It is called as the adductor tubercle, right. So there is a deliberate gap. So over here, this is the place which is called as the adductor tubercle, because this connectivity, it is quite small, right. Otherwise it is connected all the way to this femur. So in between we see this gap, right, and this gap, this gap, right, this gap, that is what is called as the adductor hiatus. Now this is very crucial, because it is this point from where the blood vessels from anterior to posterior and posterior to anterior, right, they will be communicating. Vessels will be going from here, they'll be going into the posterior compartment. So that's the point where they will be changing the plane from anterior to posterior. And this entire line, right, this is what is called as the linea aspera, A-S-P-A-R-A, linea aspera. Yes, the clinical session, that will always be coming at the end, right, definitely. Okay, so here it is linea aspera. So if it is asked that on femur where exactly the adductor magnus is connected, one would be the linea aspera and second would be the adductor tubercle. So this is one and second is adductor tubercle. In between there is adductor hiatus, which is giving the space for the blood vessels to move from one compartment, that is anterior, to the posterior, right. Obviously over here we'll be saying that it is the ischiopubic ramus. Now over here, when it is ischiopubic ramus, that means pelvis is steady and the leg is free to move. So when the adductor magnus acts, so obviously it will be acting like this, right. It will take the femur towards or near the body, right. That is the adduction. So this is one. To this we just add, on this level, right, we just add two muscles. So adductor magnus is at the base, then comes adductor brevis on it, and then on top of it adductor longus. Now when adductor longus is there, right, over here I'll first show, here is this small one, right, that small one, this one. In fact, let me draw it, right, on this one. It is just this one, right. And now you should be able to visualize the adductor longus quite well, right. See, this is this one is adductor longus. Now I'll remove it and see. Now you appreciate, correct. And if I remove this, it makes things much clearer. So this is, I'm just drawing this dotted line, and this is the dotted line which is giving the markings for adductor longus. Now there is one very important thing to remember. Adductor longus ends just before adductor hiatus, right. This adductor longus ends just before adductor hiatus. Yeah, that's what I'm doing. That's what it has been done. Not only the border, in fact I painted the muscle so that you understand it properly. I'm doing it again. Say this is this is what is there, right? That's the adductor longus. The idea is it ends just before adductor hiatus. After drawing this, why I am removing? Because I really want to say appreciate you the real structures, right? Because if I keep on say painting all the muscles, you'll be losing the real content. So that's the reason after explanation I'm removing all this, right? So that way you see this, that this is how in real life they look like. Because see, all the images, right, both of you will be getting it in any case, all those drawn in the books and all those graphical images that you always get. I really want that you visualize it, right? You watch these real structures, because as someone said very correctly, that she saw these structures for the first time, and they look so different. Yeah, actually they look very different. And I really want you to prepare it in that way that when you see it in real life, you should be able to identify. So that's the reason at times I keep on telling you the points which are important from the perspective of the understanding that how they look like in real life, right? So that when it really comes to when you go for surgery, when you go for any of the stream, you see the muscle and you should be able to say that what exactly it is, right? Okay, so as we said that this one, right, adductor brevis is that small muscle, right? It is overlapped by adductor longus. So this one big one at the base, that is all adductor magnus, right? Remember the layers. And then we have got the adductor brevis, and on top of it adductor longus. But this adductor longus, it ends just before the adductor hiatus. All these major points are covered, right? We have covered all these major points, so do remember this. Okay, see, seen much clearly, right? This is in fact the same view but with slightly photoshopped, so that these muscles, they have been painted, right? Not much of the variation I have done, just minor variation, but I tried to create a contrast so that you can really see those muscles and their orientations properly. So here it is, right? I need not say which muscle is this, I need not say which muscle is this, and I need not say which muscle is this, right? So he is the grandfather, right? Here is the father and here is the son, right? So let's keep it this way, right? Father, right? And the son, right? He is the great grandfather. But what we really want to appreciate, watch this adductor longus border, and this border ends here, right? So we'll put this point. That's the point which we really want to remember. Okay, and you also know this point, and that point is that this adductor longus stops before adductor hiatus. Now this point is important because sometimes when there is any confusion, right, we do reverse engineering, right, because we are very good in that, right? So that is that this hiatus, so it is very easy to figure out. So from hiatus we figure out that which is the muscle which is ending at that, and then you reverse trace it and you say then confidently, "Kare boss, this is adductor longus, no doubt about it," right? It is because of that reverse engineering thing. So this is one important point. We'll put star on it. Good. Okay, let's move further. Now see, we are adding something more to this. One small muscle, one large muscle, right? Rest of the muscles already known to you, and this is like one still better view, because this is the point, that's the point which we are trying to emphasize. Which point is this, right? Which point is this? It is adductor tubercle, right? That's the adductor tubercle, because that entire line is called as the linea aspera, right? Linea aspera. So where this entire adductor magnus was getting connected, and then we have got this adductor brevis, that's the adductor longus, and this one is adductor magnus. This graceful long muscle, medial most muscle, right? A muscle which is very important, and it has got tremendous importance, and the function, it is none other than the graceful gracilis, correct? That's the gracilis. This is most medial. Now we had talked about this muscle, that okay, it is called like honeymoon muscle, but its importance is that this is the muscle which can act on two joints together. Means it can act on either hip joint, it can act on knee joint, or it can act on both the joints. This is because it starts with pubis, right? Here it is, this is pubis, so it starts at pubis and it is not ending on femur. It ends on tibia. It ends on tibia. So this is the interesting part, that it crosses, this is the gracilis, which crosses hip joint and the knee joint both. It crosses both the joints, right? So that's the thing. This is important. This has got specific importance. That's the reason that it will be acting as an adductor of hip joint, at the same time medial rotator, right? So this is the reason. Okay, now only one muscle which is left out, shortest muscle, and that muscle is our pectineus, right? How can we forget it? Here is the pectineus. So that's our shortest muscle. Shortest muscle, right? The large muscle have to cover small muscle, but it's quite different here. No. There is no such rule like that, right? There is no such rule like that large muscle has to cover the small muscle. It's not like ocean that large fish will always eat the small fish. This is like orientation. That's the reason that we said that we'll be learning from the functional aspect. Over here, the reason behind it is very interesting. If you really see that in car, in any of the racing car, there are gears, right? So there are bigger gears, and then on top of it there are smaller gears and smaller gears and smaller gears, right? The bigger gears, they are always at the base, right? Over here, it is one of the wonderful system created by the Almighty. The large base, the large muscle, it is at the base, right? So it is getting the maximum surface area. So it is taking the maximum linea aspera. Then whatever the amount which is left out, right, that is given to all those chota muscles, right? So because if it is like if you put the small muscle at the base and then you try to cover it with a larger muscle, so there would be few spaces left out, because those spaces they were covered by smaller muscles. Over here, first choice is given to those large muscles. So he creates his entire territory, his entire domain, right? And then whatever is left out, right, all those things, and then small muscles are kept. Technically speaking or mechanically speaking, small muscles, they are for the finer control. Large muscles, they are for the bigger and the most powerful controls, right? And these muscles like gracilis and pectineus, they give the finer movement and the finishing touch. So actually when we go for the kinesiology, That is how all these movements, that is at what degree the movements they occur. You will find that the entire arrangement is so beautiful, right? It moves seamlessly. And especially when we'll be discussing the exercises associated with it, at that time you'll really enjoy that. Okay, this is what we really want to achieve, and these are the exercises which we'll be doing, right? Okay, so these are the muscles, right? Adductor family and the pectineus and the gracilis. So we have got the 5 muscles, right? We have got the 5 muscles for our adduction. So we just say, okay, so these are the 5 muscles. Chalo. So that is done. Okay. See, just a look at the pectineus, right? As such, this pectineus is getting so much of importance, because when I said that forget about this muscle, no one ever forgot it. Okay, and here is someone who is hidden underneath. This is adductor brevis, because it is a small one, right? A deeper one. On top of it, this one, no doubt about it, this is adductor longus. Okay, moving further. Now see, all these muscles, I think most of the muscles now they are known to you, right? This is slight change in the angle, slight change in the angle. This one is piriformis, right? This is piriformis. And over here, we have got all those deep muscles, right? All those muscles which were the short rotators, they are arranged one after the another, right? So this is that portion, that is obturator internus, plus there are gemelli, right? Then from the shape itself, this shape is so classical, so we can't miss it. It is quad femoris, and underneath there would be the obturator externus, right? So that is good. Okay, let's, yes. Now this is where we'll be dealing with the abductors. We saw adductors, so they were very easy. Just from the ischium, if you just connect to the medial aspect, and everyone was connecting to medial aspect, right? I'm not telling only femur, because the gracilis was going towards the all the way to tibia, but anyway, it was also say covering the medial aspect. So everyone was connecting to medial aspect. So pull it, obviously the limb will be moving towards the body. This is where we are dealing with abductors. So that means they will be going away from the body. If now it is away from the body, we can't tell that okay, those muscles will be connected to somewhere else and from there they'll pull. Here comes the principle of joint. This portion is steady, right? This portion is steady, and here is a joint, and here is that movement. Here is the portion which will move. So if I connect it like this, and then if this portion contracts, so mechanically this limb will be going like this, right? That is what is happening. It has to glide over the joint so that when it pulls, it will just lift it, right? So that's how it goes. The shortest muscle of adductor compartment. Yeah, adductor compartment. Adductor compartment or leg. No, I'm not getting it. Or leg means it is adductor compartment of adductor part of the hip. Okay. So here it is, abductor. So the point is that that's how it will be acting. So over here, see, this is what, this is greater trochanter, right? This is greater trochanter. And all of them, they will be going like on the greater trochanter and then getting attached. So when from that point, when they will pull, right? So this is the whole femur. And if they pull it from here, the rest of the limb automatically is going to raise. But when you do this thing, this has got tremendous mechanical disadvantage, because if you pull from here, right, it will be much more easier. It is exactly the same way in 36 chamber of Shaolin, right? When there is an exercise shown, right? He was preparing for those martial art training. So there was a long rod. The teacher asked that what is the weight of this brick? He said 1 kilogram. He said no. It looks like 1 kilogram, right, when it is in your hand. But when you hang it over here, it becomes 20 kilogram, because you are raising it from here. So here is, the longer the distance, bigger the disadvantage, right? Bigger the disadvantage. So that's the reason that when you are putting this entire movement, right, all these muscles here getting connected on greater trochanter, right? And it is that from greater trochanter you are squeezing it and then you are moving it. That's the reason that gluteus muscles, they are so big as compared to rest of the muscles, because there is a clear mechanical disadvantage. But that mechanical disadvantage has been converted into mechanical advantage in a very classical way. Very classical way. So when we write it over here, that which are the abductors, we can very well say that gluteus. And then the moment I say gluteus, the first thing comes in the mind is that big boss, right? Gluteus maximus. Sorry, no gluteus maximus. Gluteus maximus has got no role in abductors. Well, we'll say that gluteus maximus is the bigger one, biggest one. No, but its attachment is such, it has got a very special role, right? And it is quite interesting. When I'll say, you will laugh, right? It's not, you'll laugh because it's like a joke, but you'll laugh because you must have seen so many times, right? Okay, so I'll come to that, right? So it is the gluteus minimus. It is the gluteus minimus and the gluteus medius. Gluteus medius, which are the actual abductors. But then there is someone called tensor fascia lata. Now this tensor fascia lata is a muscle, right? It's a muscle. Fascia lata, right? There would be fascia. So that there is a fascia, we'll be coming to that there is a fascia which will be covering all the muscles of the thigh, and then on the lateral side it is thickened. Once this fascia is thickened, so that fascia will be acting like a sling, and on that when the muscles attached, so actually when the muscles are contracting, that's okay, we feel it that they are getting attached over here, but this attachment is in the form of a thickened fascia all the way. So that means the attachment is over here also. In fact, it is on the entire limb. That is how that even though medius and minimus are small, but still they go for a very fine abduction, right? Because they are in support with tensor fascia latae, right? We'll see it in more detail. So what you are watching over here, this is gluteus minimus, right? That is gluteus minimus, that small muscle. Okay, let's see this bit more. Okay, see, that one is ilium, or the iliac crest, right? And this one is greater trochanter, and this muscle is gluteus. From its attachment, we can say, right? From its attachment, this is gluteus medius, right? So that's the reason that when this thing would contract, yes, we say that it will be leading for abduction, right? It will be going for abduction. Now, it is not necessary that all the fibers should really contract exactly at the same time. So that's why when only the partial fibers they contract, so with support of other muscles, remember that gluteus medius can also be one of the medial rotator, right? Also medial rotator, right? Just keep in mind. Yes. So here it is. This is the entire fascia. And this fascia, this is called as the fascia latae. The fascia which is covering everything, right? See, this is absolutely intact fascia, right? Completely intact fascia. So that is fascia latae, right? Intact. Now this intact fascia, it is lateral portion, right? What we are watching is lateral portion. So there is a lateral thickening. This is lateral thickening. And this lateral thickening is what we call iliotibial tract, right? Because this thickening will continue all the way. So that thickening is what is called as the iliotibial tract. Now from the name itself, you can say from ilium to all the way it will go towards the tibia, right? So this is what is called as the iliotibial tract. This fascia lata, it is a fibrous tissue, right? It's a dense fibrous tissue, correct? This is a dense fibrous tissue, and it would be covering all the muscles of thigh, right? So like this, right? Covers all the muscles, covers all thigh muscles. But this is thickened laterally. So because it is thickened laterally, there are two muscles which will be taking advantage of it. That as such, there is lateral thickening, and this lateral thickening is so powerful. So why don't we use this surface for the attachment? And that's what it is done. See, this is two muscles, right? That is the gluteus maximus and the tensor fasciae latae. You remember? We said that tensor fasciae latae is a muscle, right? It is this muscle, this one. So that is tensor fasciae latae. So again, what I am telling is that fascia lata is something which will cover all the muscles of thigh, right? The outer sleeve, but it is thickened on the lateral side. So we call it iliotibial tract. Here it is your iliotibial tract. Iliotibial tract. This iliotibial tract is going all the way till the tibia. Now this is tough, right? It is tough. It is thickened. So that tensor fasciae latae, that muscle, he tells that okay, gluteus medius and gluteus minimus, right? Minimus and medius, you do your work, but I am going to take one very nice step. He goes and he gets attached to this iliotibial tract. When he is attached to iliotibial tract, any of the contraction of tensor fasciae latae, this tissue is a fibrous tissue, so it will straight away be putting the effort all the way up to the knee joint. So this is like a sheer mechanical advantage, a huge mechanical advantage, right? How interesting. And this is the muscle, this is the big boss, gluteus maximus. Gluteus maximus. And the gluteus maximus is important for a very amazing reason. We said that it is not taking part into the abduction, right? You know what it is doing, right? It's like it is for boys, females don't listen, right? But it is important, that's why I'm telling. Well, it is important for everyone. But the thing is that what's the function of maximus? Function of maximus is that when you walk, right? When you walk, so walking is like this, right? You walk like this. So there is one point when the opposite leg is just into the air. Now it is just into the air, right? Till it lands onto the surface, right? Till it lands onto the surface. Till that point it is into the air. It is at that point the gluteus maximus will balance the body, right? So what it will do, it will tilt the pelvis slightly, right? It will tilt the pelvis slightly so that it balances the body. The moment there is landing, right, the opposite foot lands, the pelvis is straightened, and then the vice versa. Then the opposite gluteus will take into action, will come into action, because now this leg is into the air, right? This is enhanced when person is climbing the stairs, or when there is uphill running. That's the purpose of gluteus maximus, right? So it is the tilting of pelvis which is so important, so that and that is what is really taught to those models, because that's what makes them more sensual, right? And there is a very classical reason that why the tilt of pelvis is more in females as compared to males. In males you don't get that much tilt. That is what we'll study when we'll be discussing the pelvis, right? Because there are so many reasons. And in fact, there are a number of reasons that the entire structure of the hip bone is different in case of male and in case of female. In fact, in osteology, we can take that. Okay, we'll take one session in lower limb only, right? We'll take that session. Okay, because right now we'll deviate from the topic. So I'm just writing that it is the tilting of the pelvis, right, while walking, right? Each time when we walk, or when the step is taken. So I'm just taking the step, right? I think this much should be enough to give you the idea. Okay, so you got the whole part, the perfect picture. The gluteus maximus, the function, the tensor fasciae lata, right, that is getting inserted onto the iliotibial tract, and because it is fibrous, so that is the entire tough portion which will go till tibia, and that's how it will work, right? So we talked about abductors. So abductors were gluteus minimus, gluteus medius, and the tensor fasciae latae. Done, right? Okay, moving to the next one. Yes, they are very easy, very easy, because these are the flexors, right? They are the flexors. So all those crunch when you do, right, those crunch, so those crunches, they are like thanks to these flexors. Crunches and for flexors, yes, because again these muscles are like that when the body is straight, so it is the movement of the leg. But when you lie down and you fix your legs, so it is at that time it will be helping the body to come up, right? So that's the reason that it is these flexors, they will be utilized when you actually do the crunch, but you have to do the crunch in a very correct way so that you deploy only these muscles. We'll see to that, right? So now what we are trying to talk about is flexors. flexors, right? And in flexors, very easy, extremely easy. One, none other than our Swas brothers, and in that also it is only the elder brother who is working, that is the Swas major. Swas major. This Swas major, you can just have a look at it. Here is our Swas major, this one, that's a Swas major, right? And if he is Swas major, here is his partner, right? And that is iliacus, correct? So that is iliacus. This Swas major, you can see that it is coming from almost 1, 2, 3, 4, 5, right? All those L1 to L5, they are L1, L2, L3, L4 and L5. They are giving fibers of this Swas major. So transverse process of L1 to L5, right? Now there is one structure which we have not talked much about it, right? In fact, over here that structure has been removed, and that structure was inguinal ligament. So from anterior superior iliac spine to pubis, here is the inguinal ligament, right? That is inguinal ligament. So this Swas major will go underneath this inguinal ligament and will go all the way to lesser trochanter, right? Lesser trochanter. Greater trochanter was out. Lesser trochanter is medially, right? It is medially. It is inside, pretty inside. So it will, this is the transverse process. It will under, right, inguinal ligament, and it will land on lesser trochanter. So it means things are almost in straight line. So this powerful muscle, this Swas muscle, when it will contract, right, it will either do the flexion or it will do the crunch, right, depending upon who is stable. Whosoever is stable, and accordingly the movements would be there. So we'll say flexion of thigh or crunches. Correct? So that is one. Another one, he is a weak flexor. He is not that as strong, but still it is considered as a flexor. So he is rectus femoris. Rectus femoris, which is part of that quadriceps femoris, which was having 4 heads, 3 vastae and 1 rectus femoris, correct? So this is the rectus femoris, which is a weaker one. But then there is a very classical one. There is a classical sartorius. Right? So which will be acting like a flexor. Now why sartorius? Because it is going all the way from anterior superior iliac spine to on the medial surface of the knee joint. So again, this is the muscle which is crossing both the joints, right? It is crossing hip joint and it is crossing the knee joint. Due to this reason, sartorius, it can play a very interesting role. It is fine, sartorius, because it is crossing all the way, and when it will contract, it is definitely a flexor, but with association with other muscles, it can, especially during all those dance movements, right? These are the muscles which are creating all those interesting moves, right? So we have got one, Swas major, second, rectus femoris, and third one, that is the sartorius. Yeah. See, in this, right, very clearly you can see rectus femoris, right? And we have got, this is like above acetabulum, right? So above acetabulum, and over here, that's what is rectus femoris. See, in this case, that's the sartorius, right? This is sartorius. See how it goes. All the way, this is the anterior superior iliac spine. And from this anterior superior iliac spine, here it goes, it goes all the way, and it is almost at that knee joint, right? So when it is going this is flexion of hip joint, right? Another point is that when this muscle contracts, right? Sorry. If I say it can also lead to lateral rotation, how interesting would it be? Can you visualize? It can, if there are muscles which are supporting, right? And so when this contracts, actually it can lead to this lateral rotation, outward rotation. Sartorius is known for lateral rotation. Lateral rotation. Right. Because it is connected laterally and it is connected on the medial side. So that's how it moves. Similarly, if the leg is steadied, and then when you do the cross crunches, right? When you do the cross crunches, it is at that point, if you focus, your sartorius is definitely contracting because your legs are steady. So now your trunk, it is getting pulled on the opposite side, right? So that is where it is like this position, right? Say that's the body, that's the head, right? The position is this, and our hands are like this, and we are trying our elbow to go towards the opposite knee, and it is at that point, not only that, our knee is also coming over here. In this, if you'll focus, you'll find that even the sartorius is acting, right? Because over here, as the lower limb, as this portion is fixed, right? So that sartorius which is connected over here, he will contract so that this leg goes for the lateral rotation, right? There are so many movements, but we'll talk about it. Okay, let's see something more. Extensors. These are the extensors, just the reverse of flexors. Yes. The iliotibial tract, right? It will be almost at to the medial aspect. Yes, it comes all the way till this point. That's right. So over here, now we are dealing with the extensors. So for extensors, we'll be deploying hamstrings, right? That is the back of the thigh. And we call them hamstrings. And in hamstrings, we have learned three muscles, right? The medial most was the semimembranosus, and then semitendinosus, and then there was biceps femoris, right, on the lateral aspect. And biceps femoris, that means two, right? So it was having two heads. Okay, so let's see that thing first. Here it is. Biceps femoris, right? Biceps femoris. This is the lateral aspect. This is the lateral side. membranosus is medial, right? And this is semitendinosus, right? That is under the semimembranosus. So over here, say we have got semimembranosus and the semitendinosus. Right? Now the point is, one interesting thing, that it is from ischial tuberosity. Right? This is from ischial tuberosity. These extensors, they are from ischial tuberosity. That's from where they are arising. Right? Now, obviously, right, because it is the back. So for just this, let's go back to one image which we learnt yesterday. No, I think we learnt it in the first part. No worries, no worries. Because in that, semimembranosus and semitendinosus, they were shown much better, much better. Okay, no worries, right? So this is like semimembranosus and semitendinosus, and say next time I'll show you one figure in which it is seen still better, right? In this it is not seen very clearly, right, because they are overlapping quite a lot, but I'll show you one. Okay, so these are like two heads, right? Biceps femoris. So when we say biceps femoris, so it means it has got two heads, right? Two heads. One is the long head and second is the short head, right? So that short head is this, and that's the long head. This long head will be going towards the ischial tuberosity, and this short head will be going towards the linea aspera, right? Simple as that. So long head, as we said, that all these muscles that go towards ischial tuberosity, posterior to posterior, right? Posterior to posterior, they are not changing the planes. So when posterior to posterior, right, it will extend. And similarly on the anterior side, when there was psoas major, so it is anterior to anterior plane, so it will contract. So then it is the flexor, and from the back side when it is contracting, it is the extensor, right? No big rocket science. So this is ischial tuberosity, that is where this long head is connected, and this short head, that is at the linea aspera. Linea aspera. Right. This is, as these both heads they meet, right? They form a common tendon, right? So this is the long head, this is the short head, and when they both meet, this leads to formation of tendon of biceps femoris, right? The common tendon of biceps femoris. And on lateral aspect of the knee, this will go, because on the medial aspect we have got the tibia, on the lateral aspect we have got the fibula, right? So this tendon will be inserted, right? The insertion of this tendon, that will be on the fibula head, right? Fibula head. So that's where the insertion would go like, because this is lateral most, right? This is on the lateral side. So on the lateral aspect of the knee joint, this biceps femoris tendon, right, that will be attached on the fibular head. Now over here I am also preparing you for the knee joint. because over there you will see that, okay, when there will be collateral ligament, tibial collateral ligament, fibular collateral ligament, one will be inside the knee joint, one will be the outside of knee joint. So then who will be supporting? So it is there, the tendon of biceps femoris will come to support the knee joint, right? So that's why we are discussing it like this. This figure, keep it in mind, very important, because on the lateral aspect of the knee joint, it is the common tendon of biceps femoris, which is pretty powerful, right? In fact, you can even feel it in your leg, right? So that's how it is connected. In any case, in knee joint, this will be coming with quite a lot of detail. See, that's what it is. It is seen, right? This is how it fans out. See, over here, right? That's the fibular head. That's the fibular head. And this is the biceps tendon. Right? Biceps femoris, obviously. Okay. So here it is. Once again, we are back. This is gluteus maximus. A question was asked, is it that gluteus maximus covers that obturator internus? Yeah, definitely it covers, right? Surely it covers. You know, it covers partially, because the portion which is inside the pelvis, and then when it comes out, it takes that 90-degree turn and then it passes, right? And then it is in association with above and below, gemellus superior and gemellus inferior. So it is that end portion, right? It is that end portion of obturator internus, and on top this is gemellus superior, over here it is the gemellus inferior, and over here it is the quadratus femoris, and then that entire thing is covered by gluteus maximus. Yes, it is connected, right? So that way we can say that yes, it is the obturator internus is also covered by gluteus maximus, but partially. This is what we saw, right? This is this one. So that one is tensor fascia latae. So tensor fascia latae and the gluteus maximus. These are the muscles which will be connecting to that iliotibial tract, right? No problem. Yeah, so that's what I was saying, because this semi-membranosus and semi-tendinosus, because they wind around. So that's why in next session I'll be giving you one very nice figure, right? Because why it is semi-membranosus? Semi-membranosus is like all fleshy, and semi-tendinosus, right, there are tendinous sheaths. So just hang on for semi-membranosus and tendinosus, because I immediately figured out, because in that it was not seen very properly. So in next session I'll definitely be showing you this, that how it gets converted into that tendinous part, because that tendinous part was not seen over there, right? So just hang on for this much part. Okay, so this gluteus maximus, the upper 2/3, right, it will be going for this iliotibial tract, right? So this this one, right? So this upper 2/3, that is for iliotibial tract, right? And lower 1/3, this lower 1/3, that will be going on the femur, right? This will be going, this lower 1/3, that will be for the back of femur, right? That will be on gluteal tubercle. So thus the flexion okay. So by hamstrings, right, when the hamstrings they will be working, they will be going for knee flexion and hip extension. Got it? This is important. So it will be going for knee flexion and hip extension. Right? That's what it is needed in normal plus in normal walking. That is where the gluteus maximus will come into picture. Right? So that's by hamstrings and this is by gluteus maximus. So this was for the hip movers, right? One important point before we finish up. These muscles, they are also called as the anti-gravity muscle. Anti-gravity muscle, right? One of them is gluteus maximus and the second one is quadriceps femoris, right? Quadriceps femoris. Yes, these two muscles, they are called as the anti-gravity muscles. Anti-gravity muscles, they are those muscles which are helping when you are climbing, right? When you are going uphill, right? So climbing stairs, say for example, or when you are going uphill, right? And the most important is, for proper development of these muscles, the best exercise is squats. Squats. Now, you'll be very much benefited if you go for wall squats. It is called as the wall squats. What wall squat is? Normally when we do the squats, right, our knees, they cross the toes. If the knees are crossing the toes, you are injuring your knees. So what you do is, this is the wall. You stand in front of the wall, right, with about say 1 feet of distance, not more, and then try to bend the legs, right? Try to bend and try to go down. Now, as you are standing over here, by no means, because of the wall, you will be crossing the toes as the wall will come down. But the chances are you won't be able to go much down because you can't do any cheating. Normally, if there is space, we try to balance it by tilting the body, right? Or even the legs, they are over here. The knee joint is also not at 90 degree. But when you try to do this thing, your wall is there and then you try to bend. So definitely, right, it will be generating pressure on the hips as well as it will be generating pressure on the quads. Both of these anti-gravity muscles would be deployed when you do wall squats. I think even if you Google wall squats, right, you'll be able to get it. Otherwise, it is very simple. All you need to do is squat is just you keep the entire body straight and then you try to sit on the imaginary chair, right? It is like sitting on the imaginary chair. That's it. But over here, instead of taking support of the wall, you are facing the wall and then you are doing it. But that's the trick. That is what is called as the wall squat. You just do 10. I'm not telling you to do more. You just do 10 and see what happens. Right? If done properly, you'll feel it on the next day into your gluteus maximus and your quadriceps femoris. That is in the hips and the thighs. You'll feel the pain. That is the lactic acid accumulation. But yes, that is what leads to the growth. Right? Yeah, it is anti-gravity because see, you are trying to sit on the chair, right? And gravity is pulling the entire body and gravity wants that you fall. You are not falling. It is simply because of the gluteus maximus and the quadriceps femoris because they are holding the entire body. Otherwise, gravity is interested that you fall, but they are holding the entire body in this position, right? As if you are sitting on the imaginary chair. That's why they are called as the anti-gravity muscle, Okay, so that's it for today, right? I'll write thank you over here. Thank you so much, and we'll meet on Monday, right? On Monday, we'll be starting with the hip suppliers, plus I'll be showing you some of the extra images which I feel that they are needed, right? And then we'll be going for the blood supply and the nerve supply. Thank you so much, and we meet on Monday. Bye bye. Thank you.